webinar, which I'm excited to host. My name's Zohal. I'm an infectious diseases pharmacist here at NCAS. Most of you will know that last Friday was World Sepsis Day. And so to continue this important conversation, we have two excellent speakers lined up for you. And I want to thank both Sadid and Celine for joining us this morning. I'll introduce our first speaker. Dr. Sadid Khan is an infectious diseases physician and clinical microbiologist working at both Alfred Health and Monash Health here in Melbourne. He has professional and research interests in the management of infections in critically unwell patients, and he works quite closely with the intensive care team to optimise patient care and provide education. And I will let you take it, President.
Well, thank you very much for the opportunity and introduction, Zohal. I'll share my screen. I'll just confirm that's presenting and people can hear me.
Yep, that's perfect.
Wonderful. So thank you again. So I was asked to talk about the topic of optimizing antimicrobials and sepsis. And the way that I've kind of structured this is a bit more of some practical considerations and things that working across two, large ICUs, things that we encounter in kind of day-to-day practice, the kind of areas which I think are, things that are, if you're not implementing, I think it's worth considering implementing, kind of things that we can practically improve, at the current point in time to optimize how we give antimicrobials and sepsis. And this is how I've kind of structured the talk. We'll talk about these four main kind of areas about, management of antimicrobials and sepsis, choice, what dose should we use, how should we administer it, and then kind of the thing that we often think about the next day, how to reassess and, refine our choice of antimicrobials in the management of sepsis. The things that I won't have the opportunity or time to talk about are just as important, but, the recognition of sepsis, which I know that, many people on this call have put a lot of work into, identifying sepsis early to make sure we actually implement these things. And that's probably one of the most critical things. But beyond the scope of the talk today, fundamental to all of this is provision of good critical care. So that starts in the, the emergency department or, wherever the onset of sepsis is and progresses to, places like the ICU for some of the severe forms, and being able to actually support your patient through sepsis goes hand in hand with the administration of antimicrobials. That should give us a bit of a buffer zone as well. So, if, the better the critical care is, if we are slightly suboptimal in our antimicrobial choice for whatever reason, that gives us a bit more time and opportunity to improve and kind of refine our choices. Source control for, deep-seated infections, it's just as important as the choice of antimicrobials, often more important in some scenarios. So forgetting to address that can often, is to our detriment. We can fiddle with antimicrobials as much as we want, but it may not necessarily fix the problem without addressing such things. And with the increasing use of immunomodulation around the management of sepsis, where sepsis has an immune dysfunctional component to it as well. So the use of steroids, for severe community-acquired pneumonia, as an example, is another, common theme that is being increasingly used and used as part of sepsis. And so I want to frame this by talking through a case that we had the other month, which I think is quite illustrative of a number of points. So this is one of the ICUs I work with is a large burns ICU, an adult burns ICU. So this was a 32-year-old male that had quite a large total body surface area burn from a house fire up to 65% of their body. They were admitted straight to ICU, and we saw them on day 10 of ICU for essentially new onset hypertension and fever, so sepsis in a prolonged ICU patient. He was otherwise quite a young, fit, healthy gentleman. Review of this patient at the onset of sepsis, his burns were clinically infected, having otherwise been progressing relatively well up until this time. And he had had prior swabs of his burns, so we knew what he was colonized with in a way. So it was a methicillin susceptible Staph aureus, drug susceptible Pseudomonas, and an Acinetobacter baumannii complex. So kind of not something that is unsurprising for a burns patient that's about a week plus into a hospital stay. And importantly, he'd recently, because he had lots of airway burns as well from his house fire, had recently completed a 7-day course of meropenem for an Acinetobacter VAP as well. So one of the questions, but the first question is, what antimicrobial should we give this patient? This patient has sepsis, which we astutely recognize, but what we actually do for this patient. And I do a lot of teaching for ICU as well as the physician trainees and infectious diseases registrars as well. And I often ask them, because of my talks, what are some important take-home points? And this is kind of the three most common things that people have said are kind of useful things that they found in terms of helping think about antimicrobial choice. And so, and this is also a way that I think about it as well. So how do you choose an empirical regimen? Um, so defining a clinical syndrome, which in part requires, the ability, time and ability to do an accurate patient assessment. And, what syndrome that you're worried about defines what organisms that we need to cover and what we're worried about. And that helps us decide about a specific antibiotic choice. But then beyond that, how sick is your patient? Can I afford to be wrong? Someone with a mild cystitis is very different to someone in septic shock in ICU, where the chance of them being alive the next day is substantially different. So, and in addition to that, risk factors for antimicrobial resistance. So both of those things, modify how broad we need to be. That may change, our initial antimicrobial choice, which is really goes into, can we afford to be wrong and make a change the next day. And then important patient modifying factors that may affect our choice of antimicrobial or the dose of antimicrobial. And that includes allergies, renal function, noting both augmented renal clearance in this cohort, as well as a higher incidence of acute kidney injury. What's their liver function? What's their weight? Noting in particular extremes of body weight. And then other immunosuppressed, which modifies both the types of organisms that they are at risk for, the risks for antimicrobial resistance, but also the thresholds or what's the appropriate targets for our dosing, which you often aim a bit higher in terms of immunosuppressed patients in terms of optimizing dosing and exposure. Balancing risks and benefits of your antimicrobial choices. So obviously, we're giving antimicrobials because we perceive there's a potential benefit in this patient that's developed sepsis, but we know the antimicrobials have harmless as well. So that in part relates to your, how unwell they are, what's the risk of antimicrobial resistance. So trying to achieve that balance is one of the key challenges of antimicrobial stewardship in this area, from maintaining effective and appropriately broad therapy without causing undue harm to the patient, but also for the healthcare environment as well. So you could give every single patient meropenem in the hospital, and that would certainly be, kind of broad cover, but that would have undue and probably inappropriately detrimental effects on the healthcare environment. So trying that balance again is one of the key things we have to deal with. And the third point is not specifically related to antimicrobial choice, but I think is a common point of confusion for people when they're thinking about antimicrobial resistance. Just because a bug is more drug resistant in itself is not more pathogenic in a way. So just because something looks scary doesn't always necessarily mean it needs to be treated in terms of colonization, or kind of thinking about theoretical risks as well. And in terms of practical things, in terms of optimizing antimicrobial choice, I think this is one of the hardest things that we could potentially do, because there's so many things that can be done that are also quite challenging to implement as well. But I think some of the more higher yield things, and this first one here is actually a national safety quality healthcare standard. So having updated local antibiograms and in the healthcare institutions performing antimicrobial resistance surveillance. So we actually know what is in our healthcare environment at a local level. And that, while is much more challenging to implement for a patient level decision, is quite useful in terms of structuring guidelines, and long-term trends give us a sense of how we're doing in terms of antimicrobial management, and helps us refine guidelines, which are often structured at a national or a state level, but local guidelines often end up performing much better. They're more kind of broader guidelines. As we mentioned, accurate clinical assessment is fundamental to choosing the right antimicrobial, and that is often quite challenging. This is often under time pressure and a lot of uncertainty. You have often little clinical information at the time and very little diagnostic information. And one of the things that's being increasingly used is clinical decision support. So as we just mentioned, so utilizing local knowledge of antibiograms and AMR data, you can tailor your guidelines. So as an example, in our hospitals, we have a high rates of VRE in our hematology population. So many febrile neutropenia guidelines may not necessarily include empirical VRE cover, but our febrile neutropenia is going to ICU. That's something that we've implemented. And knowing what drugs are available in your hospital, it's not useful to recommend an antimicrobial that's not available or readily accessible in your hospital in terms of acute sepsis management. increasingly so, both, people actually implementing, but lots of research in this space as well as integrating clinical decision support into the EMR as that's being increasingly used. So helping clinicians make antimicrobial decisions, so flagging important things like current renal function, liver function, allergies, but also integrating, this is the most recent microbiology results in the last 3 months for you to be aware of when you're choosing your antimicrobial. And then antimicrobial stewardship programs and infectious disease devices, you know, often present and often very helpful in these scenarios, but has a barriers in terms of additional phone calls, by having someone available, staffing. So certainly very important, and in terms of providing advice, especially for more complex cases, but with the increasing kind of the acuity of sepsis and the increasing use of other stuff, having that information available at the point of care is increasingly important and one of the important factors in optimizing antimicrobial choice. And I think one of the larger and probably more important things, as I suppose many people may have experienced, I've certainly helped write guidelines. Most people on this call probably helped write guidelines about antimicrobial choice and other things, but most people that are dealing with acute patient care either have read the guidelines and forgotten the content, or in itself not have read the guidelines themselves. So I think the guidelines are important in terms of knowing what to do and making sure that's appropriate for the institution, but what people actually learn from it, what they see around them, what they see their colleagues, what their clinicians, their senior clinicians are doing. And in terms of the education that exists for various departments, whether it's emergency department, ICU, the infectious diseases service, that's how these guidelines are actually translated into practice. So if we don't model what we do, and if we don't actively teach, what we are writing in our guidelines, they never really get implemented. A few additional things in the literature, I suppose. So there's this paper was an interesting one from 2022, which is a new approach to a new way of thinking about antibiograms. So antibiograms in general are more for surveillance and long-term trends, but this is redesigning an antibiogram, and they've called it an escalation antibiogram. So, if this patient has a ceftriaxone-resistant isolate or an ESBL, what are the most likely agents that are active? And that can be informed by local data. It's the same information, but just redesigned in terms of how that data is interpreted. So this is an example of what this might look like. So this is from this data set of the ceftriaxone-resistant isolates. You have nearly 100% amikacin susceptibility, meropenem susceptibility. And you can imagine this, and this has been implemented into clinical decision support into EMR programs as well. And then this is kind of the future. So this, at the Alfred Hospital, is one of the research groups here is looking at this Superbug AI platform, which is integrating EMR data, patient data, microdata with the use of artificial intelligence to try and, really improve that point of care decision making with, all the information that might exist, and, potentially identifying patients at high risk of sepsis, making antimicrobial recommendations, and then, with the pie in the sky approach of implementing kind of sequencing data as well to look at virulence factors, resistance factors, really, and transmission risk as well. So this is kind of what the landscape may look like in the future, but certainly still a work in progress. So for this patient, we decided to give meropenem in the context of the Acinetobacter and the Pseudomonas. He also gave this patient a stat dose of tobramycin, given the recent exposure to meropenem for the treatment of an Acinetobacter. Other important factors, so, an 80-kilogram male, he had an acute kidney injury. Noting this is a young male with a large burn, this patient, this is a classic patient with augmented renal clearance. So this patient's creatinine clearances would often be in the 150 mils per minute, 200 mils per minute. But there is a mild acute kidney injury in this context. Otherwise, liver function is normal and there are no allergies. And I put this sentence down here at the bottom. This is something I always try and teach my registrars or anyone. So when we make an antimicrobial recommendation, that is beyond just a drug. That includes a dose, a method of administration, and where appropriate, an estimated duration, or at least a review date as well. So I think that's fundamental as well. When I think about dosing, I have the drug, bug, and patient considerations. So in terms of the drug, what's the therapeutic index in the dosing range? What target am I aiming for efficacy? Is it time above MIC? Is it area under the curve, total drug exposure? And how well does it concentrate the sites of infection that I'm worried about? In terms of the bug, are there any specific dosing requirements? For example, Stenotrophomonas has a high dosing requirement. compared to an E. coli for cotrimoxazole. Is this bug one that has a higher propensity for development of AMR, like Pseudomonas and Acinetobacter? And for some drugs, combination therapy is often utilized, Acinetobacter again as an example. And a number of important patient factors, what's the syndrome? Have I had source control or the adequacy of source control? How sick are they? The risk factors for AMR, immunosuppression, as we talked about, modifying a spectrum of antimicrobials. And then these things routinely, so that it affects kind of dosing directly and choice of antimicrobials. And importantly, it's not a fixed decision. So the dose I might recommend in the first 48, 72 hours of an acutely septic patient is different to what might be relevant, a week later after the patient is stabilized, source control has been achieved, etc. This is an example of the multiple different pathophysiologies that can happen in critical illness, so how drug concentrations can be modified. From this excellent review paper from Jason Roberts, who many of us probably do know, has done a lot of work in this area. The ones relevant for our patient I've highlighted in the red boxes. So this is a burns patient, a young male burns patient with no past medical history. They are very hyperdynamic. They almost always have augmented renal clearance that means to reduce drug exposures. Burn, such a large burn, they lose lots and lots of fluid through their skin or into the third spaces, so that also reduces their plasma concentrations. And this patient has a mild acute kidney injury, that not substantially so, but this also has impacts potentially increasing in plasma concentrations. And one of the important concepts that I think is we sometimes think about, but often is probably underappreciated. So how do we modify a dose in acute kidney injury? It's pretty common for septic patients to have an acute kidney injury. And if we were to adjust dosing just based off a serum creatinine on admission, that's been studied and been shown in a number of papers which are referenced below, that we have a much higher risk of underexposing our patients if you were to, dose our meropenem based off the initial creatinine. As most patients with a septic AKI, more than half resolve within 48 hours, and a substantial amount improve, whether your dosing would be a substantially different recommendation. And so increasingly so in kind of most intensive care units that I work with, the dose adjustments for beta-lactams in particular, with their wide therapeutic index, should be deferred until at least 48 hours into admission, where you've got a much clearer example and stability of their serum creatinine. So that's to avoid underdosing in that critical period where the optimal drug exposure probably makes the most difference. And then how to administer this medication. So this is probably one of the most important trials in ICU critical care, at least for the administration of beta-lactams. The BLINK-3 trial, a number of important Australian authors, but also multinational sites as well. This is continuous versus intermittent beta-lactam infusions in septic patients in an ICU context, published in JAMA earlier this year with an associated systematic review. These trials in themselves are talked, which I won't have time for, but I will recommend, I think everyone that is involved in management of sepsis, in particular in ICU context, should be familiar with these trials. These are two podcasts that go into them in kind of good detail. This first one is from the Society of Infectious Diseases Pharmacists in the United States. They talk about the trial, but lots of pragmatic implementation aspects of the trial. And then this is a podcast from CMI Clinical Microbiology Infection, one of the journals of ESCMID, where they interview Josh Davis and talk about more of the actual trial design interpretation of the trial. But I think anyone in this space should be aware of the content of this trial. And in terms of the salient points, there are very few things that have probably shown a mortality benefit in terms of how we administer antimicrobials. But my interpretation of this trial is that continuous infusions of beta-lactams conveys a mortality benefit. Less patients die if we do this intervention. So I think it's something that every ICU is required to at least think about and make a decision upon as to whether it should be implemented. And I would be of the opinion that it should be implemented in most ICUs where it's possible. So less patients die, 2% less patients die with continuous infusions. There are better clinical outcomes in terms of clinical cure as well. This is a forest plot from the systematic review, again, showing favoring prolonged infusion. And then this is again, from the systematic review. So an improvement in 90-day all-cause mortality with high certainty evidence, again, with about a 3% 3% of patients die less at 90 days. And ICU mortality is a similar number as well. And so for this patient, and I should say, our ICU at the moment has not been doing continuous infusions, but since the publication of that paper is currently being discussed about the methods of implementation. So it's more a question of how to implement it in our ICU rather than whether we should be doing it or not. And I would suggest similar things to other ICUs that are not doing it at the moment. So this patient, in the context of augmented renal clearance and acute kidney injury, but probably should improve with some good critical care, was dosed quite aggressively with meropenem, so a 2-gram IV 8-hourly over a 3-hour infusion, which is what we commonly do with burns to such a degree. Had their stat dose of tobramycin. Blood cultures overnight grew Pseudomonas aeruginosa, which is not unsurprising given the context of infected burns that we know were colonized with Pseudomonas. But unfortunately, it was looking to be meropenem and kept as meropenem resistant. So one of the other important things is about the optimal use of diagnostic tests, and our laboratory utilizes rapid antimicrobial susceptibility testing on our blood cultures using a UCAST methodology. So this result is available kind of 6 to 8 hours after that blood culture flags, which this is a critical result in a patient that's critically unwell. We also have an in-house carbapenemase PCR, so we know that this is a meropenem-resistant Pseudomonas, but it doesn't have one of the common 5 carbapenemase genes, and this is not an uncommon thing for us to see in our burns patients. This is just a Pseudomonas that, with antimicrobial exposure, has just upregulated its intrinsic resistance and become a bit more drug resistant. So the question is what to do now, and I suppose the timing of this is important. So we are now making this decision, within 20 hours of this patient being started on antimicrobials, rather than potentially 2 or 3 days later, which may be what would be happening with kind of standard laboratory methods. And this last point is, laboratory support. So AMS programs are a critical input into what a microbiology laboratory, does, and it also helps us, stratify in terms of what are some important things that a lab should be doing to help the management of complex infections. And I would say antimicrobial susceptibility testing is one of the most critical things that we use in antimicrobial stewardship programs in terms of helping refine and target antimicrobial choices. And the ability to get that result rapidly for critical infections such as blood culture isolates is important. And there are now a number of quite readily implementable methodologies of rapid blood culture susceptibility testing. We can get a result within 4, 6, 8 hours of the blood culture flagging. And most laboratories that are resourced enough should be able to implement such things. So if this is not something that is currently accessible in your healthcare service, I would encourage you to speak with your laboratory. And I think it makes it a lot easier to implement things in the lab, but also with the clinical microbiology hat on when you have engagement from a clinical service and you say, this is important to us, can you help us set this up? Because I think this will make an important difference to patient care. And there's a lot of literature showing that a lab can do the fanciest things, but if it's not actually implemented properly, so if there's no AMS support, you can get a susceptibility testing result in 4 hours, but if no one knows about the result or acts on that result, there's still no difference to the patient. So these things go hand in hand. And increasingly utilized, but probably a bit more challenging to implement for many sites, is the routine use of therapeutic drug monitoring, which is beyond the scope of this talk, but there's certainly lots of literature evolving on this as well. And then how to best support this reassessment and refinement process the next day. So a lot of this is programmatic in terms of, what are the key areas of which we need to look at this. So in our hospital, for example, all positive blood cultures get sent to our AMS service for them to review, and minimizing the barriers for other people within the institution to access the support. So making sure the AMS team and the ID team are easy to access, the laboratory is easy to kind of get in contact with. And as we talked about, clinical decision support that's there at the point of care, minimizing the phone calls and getting in contact with someone, that information available to clinicians, and making it as easy as possible. Duration of therapy is beyond the scope of this topic as well, but probably one of the more important things as part of this refinement process. So shorter is better. There's an increasing trend for this in terms of durations of therapy. And I actually think, and this is also supported by some data as well, that If we were to focus on optimizing our durations of therapy, that has a much more substantial impact on both selection pressure, but also costs as well than, particular antibiotic choice. So arguing over piptaz versus augmentin is probably less beneficial than cutting a routine antimicrobial course from, 10 days down to 5 days, where there's good evidence for, 5 day duration, as an example. And then facilitating ID referrals for complex infections where there may be a mortality benefit or, certainly a patient benefit for that as well. And so for this patient, we know with our local healthcare institution data and our burns patients that this Pseudomonas has become more drug resistant due to its intrinsic mechanisms. We have higher rates of susceptibility to Captolazine and Tazobactam, so that's what we changed to empirically. This is the dosing recommendation for drug-resistant infections. So 3 grams every 8 hours or a prolonged infusion. This patient received 7 days of therapy with source control, with good surgical debridement of their burns, and this patient made a good clinical response. And so these are my final take-home considerations. So things that you can think about implementing at your own site if it's not already being done. So guidelines should be informed by local data, but they really need to be actively modeled within the organization so they're actually taken up and implemented. And with increasing availability and use of EMR, thinking about ways to integrate clinical decision support at the point of care, being aware of the concept of augmented renal clearance and probably avoiding that underdosing in the first 8 hours of patients with an acute kidney injury. I think in an ICU setting, beta-lactam should be given as a continuous infusion. I would certainly direct you to listen to both of those 2 podcasts because there's a lot of detail in those papers and support to understand it. But I would say that every ICU should be thinking about this. It's often more readily implementable than therapeutic drug monitoring. So TDM is a whole infrastructure where a continuous infusion is a bit more implementable for many institutions. And I would say there's a mortality benefit to this, of which many of the things we do that's not been demonstrated for. So the impetus is on us for us to really think about this. And then, the increasing use of the laboratory, one of the most important things of that is, rapid susceptibilities for critical infections, in particular blood cultures. And that's something that also is readily implementable if it's not already being done in your laboratory. So I would encourage you to collaborate with them to help improve patient care overall as well. And I think that's my last slide, Zohal, and I think I'm on time. So I'm happy to take a question or two if there's time, but otherwise, thank you very much.
Thank you, Sadid, for an excellent presentation. Thank you for going through it in such a comprehensive way with lots of take-home points. I think there's lots of key messages for people to take away, either from an individual practice, but also those programmatic recommendations that they may not be familiar with or may not have implemented themselves, but they could definitely take some ideas from. We do have one question from Ree Scarborough.
Yep.
Ree, I can read out your question, or would you like to unmute yourself and have a chat? It might be easier if I read it. There's a question regarding the escalation antibiogram. I personally found that was quite interesting. She said, that's a great idea. Have you had any feedback from clinicians about this way of presenting the data? She mentioned, do you think it would be useful to overlay the AMR risk onto the chart? So, for example, color coding it. In her practice, so Ree's a vet, they use a traffic light system to help guide empirical choices. So, any thoughts or experience with implementing that?
Yeah, so it's an interesting paper. We don't use escalation antibiograms in any of the healthcare institutions that we work at. That data is there. I mean, we kind of have looked at it in a way in terms of helping us refine our kind of protocols for drug-resistant infections. So we know that we also have, unfortunately, a relatively notable presence of carbapenem-resistant organisms in our institution as well. So we have a sense of what are the most active agents in a patient that is at risk of a CPE, and we also know what is kind of there for our our ESBLs as well. We also have a sense of kind of our Pseudomonases and a rough profile in our hematology cohorts as well. But it's not presented in the same way as an escalation antibiogram, and it's there as an interesting concept, but there are a number of practical issues in terms of getting enough numbers, depending on the size of your healthcare institution, to actually make accurate inferences, and that often may be required to get data accumulated over a number of years as well. And we don't, unfortunately, have a good way. So we use Cerner at both of our healthcare institutions, and there's no really good way to um, present that data in terms of a nice kind of sepsis dashboard or kind of integrated at the point of care. So, I've talked about clinical decision support at the point of care, but that's not something that is unfortunately readily implemented either the places that I work at the moment. But I know there is certainly talk about, you know, that idea, but at the moment it's not something that we're actively using.
And maybe we have time for one more question before our second speaker. Does anyone have any questions they want to share? The other thing, Sadid, is you've shared lots of excellent resources that I think would be great for people to follow up with. So I'll make sure I can compile them and share them with participants. We've got lots of people online. I have one easy question, a practical question that a lot of people often ask. You've mentioned the consideration of augmented renal clearance in
Yep.
these critically unwell patients. For
Yep.
those who don't have the same background as you, how would a nurse or pharmacist identify someone with augmented renal clearance?
Yeah, it's a good question. Pretty much sepsis in general is a state of augmented renal clearance due to a number of factors. And pretty much anyone that's presenting with sepsis, almost the default is to make sure we optimize our drug exposure. So, we should be dosing on a much more aggressive side, especially with our beta-lactam, which is the mainstay of sepsis. So just being aware of that as a concept that's particularly relevant for sepsis, I think is important. And you can kind of, you can get a feel for it in a way. So patients that are very inflammatory, but otherwise quite healthy. So your classic patient is the one that I described. So this is a young, fit male that'll, even at normal health, his creatinine clearance will be, 120, 150 mils per minute. So kind of, greater than 90 in terms of our GFR. And then you add on top of that someone that is very hyperdynamic because they're septic. They've had a large body surface area burn, so there's fluid kind of pumping out throughout their body. So their renal clearance, jumps up to something like 200 mils per minute. So they will clear the same dose of antimicrobial in half the time that they would give. So just being aware of that as a concept, and that to just reset our threshold. So we should be giving most of these patients the highest drug exposure possible within the limits of toxicity. And then if we were to think about lowering that dose, we should have a good reason to do so, particularly knowing that risk of underdosing with acute kidney injury is a common thing that we often see.
Excellent. I'm going to ask one more quick question. Another common question people have is around the risk of resistant microorganisms. And
Yep.
so you told us we need to look at their risk and maybe previous resistant organisms that have been identified. What kind of time frame are those previous organisms relevant for? If they've had it in their microhistory, for example.
Yeah. So I think there's three big data points in terms of helping define risk of antimicrobial resistance. So three things to think about that are probably the highest yield in terms of defining risk. The most definitive is, has this patient actually had a drug-resistant organism in the past? So do we know that they're colonized with a carbapenem-resistant organism? Do we know they're colonized with VRE or ESBL? That's probably the most strongest risk factor for having an infection with a drug-resistant organism. So reviewing their previous microbiology is very important in that context. That in part ties a bit back to that clinical decision support. So, someone in ED that's managing a septic patient doesn't have time to go through, 12 months of microdata. So having that information present, in terms of, an EMR program summarizing it for you as you're making antimicrobial choices, kind of ways to optimize that. So that's the most important one, most definitive one. The next most important one is, has this patient traveled overseas, or in particular been at an overseas healthcare institution, probably in the previous 12 months. So the highest risk period is in your first 3 months, and it kind of declines after that. So if you've been admitted to an Italian ICU a month ago, that is a very strong risk factor for carbapenem resistance, ESBLs, etc., which is actually the case that we had earlier this week. But that risk kind of stretches out to about 12 months, but especially in the first 3 months, or probably in the last 12 months, have they been had healthcare exposure, in particular overseas. And then the third one is this patient has is this a patient that's had lots of general healthcare exposure or antimicrobial exposure? That's a bit of a softer risk factor. You certainly see patients still presenting with drug susceptible infections. So, but that's just something I have in the back of my mind. But for those first two are probably the most strongest associations with the risk of AMR. And if that patient, presents in septic shock, those will actively modify my antimicrobial spectrum in terms of covering for ESBLs, potentially even covering empirically for carbapenem resistance, depending on the context and degree of risk.
Brilliant. Thank you so much again for an excellent presentation and for sharing your wisdom and experience.
Wonderful. Thank you very much, Zohal.
Next up, we have Celine. Celine is a sepsis clinical nurse consultant in Queensland. This is the first role of its kind in Queensland. And so she works for both the hospital and the health service in both the adult and paediatric sepsis roles. She's also got extensive experience working with the Department of Health in a number of different statewide programs, including digital early warning tools. So she has a really unique perspective in both the hospital and healthcare system perspective. Today she'll be speaking to us about the nursing role in the sepsis pathway, which is both innovative but essential. And I'm really excited to have her take over. Thanks, Celine.
Thank you. Okay, hopefully that's working.
Perfect, yes.
Excellent. Thank you so much for the invitation to speak. I'm pleased to see that no one's dropped off for this one. I took it upon not necessarily my role per se, but as the nurse on the floor or in ED's role, and how we identify and manage sepsis. So I think that's a really important role, and it shouldn't be underestimated. So I just want to acknowledge the Gubbi Gubbi people and the land which I'm working on at the moment. They're our traditional custodians, and on the land of which I work, walk and play, and pay my respect to elders past, present and emerging. We have quite a large Aboriginal Torres Strait Islander population in Queensland, particularly in Metro North where I work. And we have the proud, beautiful artwork for our sepsis. And some of you may have seen this before. The centre circle represents the central location, like the hospital, and the journey moves forward, backwards to the struggles and setbacks. So it's really important to recognise that not all our patients will have the same healing journey, and it's important to recognise differences. So I am the first CNC in Queensland for a hospital and health service. We do have a fantastic Queensland paediatric sepsis program and an amazing sepsis CNC that concentrates on statewide things. So absolutely brilliant service, as well as our adult service. So just some bit of plugging for the Story Bridge turned purple for World Sepsis Day, as well as this was last year Longreach, where the there's Qantas Museum turned purple as well. Just a little bit about the state. It's an extremely large state. The population is not the same as Victoria, but we certainly are extremely spread out. So the little grey area down the bottom is southeast Queensland, in which most of the population live. And Metro North is a very large hospital and health service. And ironically, Bribie Island, which is part of Caboolture region, has the highest rate of comorbidities in the state. So these are the centres. There's Caboolture, our little beautiful rural community hospital on the right, top right is Kilcoy. We've got our brand new satellite hospital on the left. For those that you don't know what a satellite is, it's open from 8 till 10:30, and it treats minor injuries and illnesses. And our very large correction centre, which has its unique issues for sepsis in itself. So I won't go too much into demographics due to time. But basically the nursing role, which I see, is we spend a lot of time with our patients. We know when they're deteriorating, and we're often the first to recognise the deterioration and changing behaviour. Around Australia, our demographics may be different, but we generally all have a very vulnerable population. Our pathways sepsis pathways enables the nurses to actually discuss and relay concerns to the medical officers and other clinicians. And I always want to say to our nurses, we are all educators, and it's our opportunity to educate our patients and family and, you know, parents in sepsis and recognition of sepsis, particularly those parents that are coming to ED with their infants or children, sending them home with a little checklist for next time so that they can be assured that, yes, they're coming, that this is potentially sepsis. So there's lots of things out there that we can use as nurses to manage our patients. We developed a necrotizing fasciitis guideline because Caboolture seems to get an extraordinary number of necrotizing fasciitis cases. And we have our own corrections pathway, sepsis for sepsis, because they're extremely unique cohort. And also our, inpatient adult, which is now including maternity cases. We all have the sepsis clinical care standard. Unfortunately, it is not compulsory. So often our facilities will concentrate on the compulsory ones for accreditation as well. But these are really important, the care standards that we try and work through. One of the most important things that we aren't getting right is care after hospital and survivorship. A lot of these patients have considerable health issues and require lots of management and direction into specialty services, so renal, etc., neuro, because some have short-term memory loss, you know, sepsis syndrome. So what's exciting, I know we're a little bit behind in Queensland with EMR. There's only about 17 hospitals that have got EMR. So we are now currently developing a digital sepsis pathway for our EMR. So we're going to have potentially we'll have real-time dashboards for our sepsis cases. There's also some significant work with University of Queensland on an AI algorithm to predict sepsis, and they've actually said that they could predict it up to 48 hours beforehand. We also need more people working in this space, like nurse navigators, etc., to guide patients through their journey, and also importantly social workers to assist with that, with all the care at home and also the long-term effects of depression and anxiety. Just going through, we don't really want to talk about too much what is sepsis, because we should all know about that by now, etc. So I'll just get into the case study because we're running out of time. We got a 7-year-old patient, female. She's come to ED via ambulance. She fell 4 days ago. She's declining. She's vomiting. She got reduced oral intake. She got a bruise to her left arm. She's otherwise intact and okay. She got a category 4. She was placed in the waiting room. She was seen by a doctor at 6 p.m. that night, so it's 3 hours later. They've ascertained is she'd fallen and hit her abdomen on the ground 5 days ago. She's sort of pain since, unable to characterise her pain. She has nausea and dry retching and lethargy. She denies any fever, chest pain, cough, very vague symptoms, quite agitated but can't lay flat. One of the problems we have in our area is poor health literacy, and this lady took 4 days to present to hospital. One of the other factors in that is you probably already know that Caboolture has been in the media for a lot of the wrong reasons over the past few years, so a lot of our community are a little bit skeptical, so they do delay coming. So unfortunately, it leads us to getting quite moribund patients in by the time they do present. The CT scan was done. There was no report or comment in the records, and she was admitted under surgery for investigation. She's got a history of the following. She's transferred to the surgical ward. She had a QAS, which is the Queensland Adult Deterioration Detection Score of 5, and the nursing staff called the registrar to review. The surgical registrar reviewed the patient and noticed she looked unwell, she's deteriorating, but there was no further orders at this stage, just to continue to observe. At that point, there would be an opportunity for the nursing staff to escalate their concern that was probably not satisfactory, but that did not occur. she continued to deteriorate by 10 o'clock. She had a Met call. She had QADs of E, which means that the patient is pre-arrest. So they have escalated appropriately in all instances, but unfortunately they didn't go further with their response for the deterioration when they had not a very good response from the registrar. No offense to the registrar. After hours, they've got a huge workload. So they did the screening of the pathway just before they called the Met call, and it looked like she has sepsis. She had an increasing oxygen requirement, and they did a lactate. The medical staff did bloods. Lactate was greater than 2. She had commenced with antibiotics and IV therapy, but no blood cultures were actually sent. So the box was ticked that they had been done, but they didn't get sent or were done. It's hard to know what happened. The CT showed the following: her abdomen with distended large loops with the point of transition, no clear cause, fecally loaded, bilateral adrenal mass. For further surgical review, likely large bowel obstruction. When they did resuscitate her, this is our pathway on the side, which shows our actions. She was fluid responsive, so her blood pressure did improve with fluid. Her saturations did require more, 15 litres of oxygen, but it wasn't actually maintaining of adequate saturation. She had IV antibiotics and sepsis of unknown source at this stage. So this is likely source control required by surgery. ICU did come to review the patient quite some hours later. And as we all know, sometimes getting into ICU takes some time. So this very unwell patient is still on the ward. And by the time she was transferred to ICU, it was 3 o'clock in the morning, and she had a diagnosis of septic shock, provisional with respiratory failure. She had a laparotomy that at 1300, so we're nearly 24 hours into her admission, and it showed quite frank necrosis of the left colon and splenic flexure, etc., as you can read there, and some patchy necrosis of the small bowel. Unfortunately, she also had suffered an iatrogenic liver injury, which was controlled and sealed, and they applied a VAC system, wound closure system. She required triple presses in ICU. She was very hemodynamically labile, poor urine output despite blood, albumin, crystalloid in theatres. She started on dialysis. By day 2, she had acute kidney injury, developing new AF and ischemic hepatitis. Her VAC output was increasing. 4 canisters since theatre is quite significant output. And she was becoming more metabolically acidotic. She was now mottled, unstable, and with a distended abdomen. Day 2 relook, same time back into theatre. Unfortunately, she suffered a cardiac arrest on the table. She went into VF, which self-reverted with CPR. They did continue the operation, and basically the patient was quite moribund, and it was not viable operation operatively. So she was for palliation. In 3:20, so this is day 2, she had her life support withdrawn. Cause of death was septic shock with multi-organ failure. The important thing is that septic shock does occur, is written on a death certificate, because unfortunately we can't pick all of them up if they're not. Sepsis and septic shock is not actually documented in the medical record or the death certificate. So just looking at how quick this case presented and deteriorated, by day 2 she was deceased. So day 0, she quite some time. When we look at sepsis identification to the time of the first antibiotic is when the screening and the first antibiotic, we look at those times, and there was some delay, but not too bad once it was recognised in the ward. And as you can appreciate, that's really not a good time on a ward for those of you that work on a ward. It's usually handover, new shift come, and things like that. There's lots of things going on a ward at that time of night. By the time they did take blood cultures, she'd already had antibiotics, so there's no surprise that there was no growth, etc. So some thoughts that I had was that she did delay the presentation, which is unfortunate. Potentially could have had a non-operative sort of management or a quick laparotomy and check. The triage category was quite low. It was a category 4. There was no documentation per se. They do not take observations at triage in Queensland. I think that's pretty common around Australia at the moment. So there's minimal documentation of observations in emergency. The fact that no blood cultures were sent is concerning as well. There was a delay to administration of antibiotics. If you look at it from triage to antibiotics, it was 7 hours. So she potentially had signs of sepsis when she presented to ED. And she had the appropriate use of the sepsis pathway on the ward once it was recognised quite quickly with those observations. There's a missed opportunity to escalate further with continuing deterioration. So she was obviously not well in ED. There was missed opportunities there to commence on a pathway. So this is where our nursing colleagues, we should be speaking up and raising concerns that these patients are not well. They look unwell. There's something going wrong. What else can we do? Importantly, she did have source control, although it was done on a regular list, not any urgency. For someone that was actually quite unwell, she probably should have had her source control done, not ideal, but in the middle of the night, where they could have a good look, not 1 o'clock the next day, which is nearly 12 hours, 24 hours from admission. And always remember, could it be sepsis? Any deterioration in your patients, particularly in new confusion, changing behaviour, is an indication that there's something not quite right and we need to have a look, and could it be sepsis? And there's some a paper there that talks about that for every hour of delay in our administration of blood, broad spectrum antibiotics in patients with septic shock, hospital mortality increases by 7% for every hour we delay. There's sorry about that picture. There's an argument about why don't we do 3 blood cultures, because this is a really interesting graph. I guess the practicalities of we do 2, which is 2 different sites. Do we really want to stab our patient again and do 3? So the practicality, these patients probably do not want to have that done, but 2 sets at the minimum. Unfortunately, I have seen some where they've just had 1 set, but 2 sets to make sure we haven't got a contaminant in another one. So it's important that we look at that. And if we're really concerned, of course, we do the 3, and particularly if they've got a central line, we do from there as well. So we have some great antibiotic guidelines that assist our nursing staff. This is just an example of our paediatric, and they love them. The ward loves them. It gives them, because sometimes these drugs, particularly on a ward, we're not giving them frequently. So it tells you how to give them, etc., etc. So it's really, and it saves a lot of time having to look up how to give these medications. So these are all developed by our infectious disease specialists that are on the sepsis statewide group, and so it's fantastic, and all the staff, nursing staff, love them. Some important take-home messages as well is, if you don't document, it didn't happen. Patients, you can screen at any time while they're in your care. And it's okay to screen a patient and screen them straight off a pathway. It is not a waste of paper, or when we go digital. But it's really important that we look at that and make sure that it doesn't matter if you screen them and they go, oh, they're not ticking any boxes, but you've had some thought that there could be sepsis. So that's the most important thing. So the other important thing, which I sometimes get some feedback and pushback from senior medical, is I say this does not replace your own clinical judgment of years of experience, but it's more of a benefit for some of our junior colleagues who may require a little bit more guidance and assistance. So it's designed to assist us. It doesn't replace our own clinical judgment and experience. And thank you.
Thank you so much, Celine. That was excellent. Having the case to go through in terms of the timeline and the summary, I think is quite helpful. I think in theory, sepsis management is quite straightforward. And so we can all say that we need to do everything within an hour, but you've highlighted some of the real barriers and challenges that can occur. We've got lots of nurses online, as well as other colleagues. Are there any questions for Celine to touch on her extensive experience? Celine has a huge role in providing nursing education. Obviously, we can't have a Celine in every hospital. We would love to have a sepsis clinical nurse consultant in every hospital doing what you do. But in the absence of that, Celine does a lot of work in, I guess, upskilling and training and implementing nursing education in her hospitals. I have a few questions. In that particular timeline, you described a few delays to care, which could potentially be modified. You've gone through some. Are there any particular aspects of that care that you think could have been optimized by the nurse, for example?
Yeah, as things, being a nurse for a very long time, I notice things have changed a lot on wards as well. And there seems to be, not talking out of school, see a lack of quite senior nursing staff. So we do have a lot, and often after hours, some very junior nursing who feel uncomfortable to step up and say, oh, I don't agree with that, which is fair enough because they are junior and inexperienced. So it's important to support them. I will always go to the new grads and say, if you have any problems, let me know. If you've voiced some concerns and you got a lot of pushback, just let us know. We can have a discussion, or or we can talk to the medical officer involved and just say, hey, it's not I don't want it to be a blame or punitive. I want it to be educational. So to say, this is where the nursing staff are coming from. And rightly, on the reverse, what I do with my medical orientation is listen to the nursing staff. They are there often at the end of an 8-hour shift. They've been looking after this patient for 8 hours. They could have had it the day before. Listen to your nursing staff, and really listen and discuss it like colleagues, because that's all we want. And so they call it graded assertiveness. So it's really hard to teach very, very new nurses graded assertiveness because there's a big knowledge gap sometimes.
Yeah, that's excellent. One of the first delays to care was, I guess, the delay in presentation by the patient. And you've made a really good point about engaging our patients and consumers and letting them be advocates for themselves. So a big part of your role and all of our roles is teaching patients about the science of sepsis, teaching their family and friends. And that's why our national campaigns are so important, to give them, I guess, the advocacy to present early and to know that they're going to be recognised and managed accordingly. So that's huge. And obviously the nurses spend so much time with the patients. They've got a good opportunity to do that.
It's a really difficult climate at the moment too. We're all facing it with the ambulance ramping and EDs full, hospitals are full. So patients see that and they go, oh God, I'm going to have to wait 8 hours. We need to do a lot more education. So I've said this before, we see all the ads about having a stroke, having a heart attack. We need to do more advertising and education for the general population in regards to what is sepsis. So that's one of the things, is they can recognise signs of stroke and heart attack so that they know to come to ED. So that's one of my things that I would love to see.
Education is excellent. You've shared some excellent resources which we can all share with our patients and colleagues. You mentioned the role of the nurse at triage. At least from my experience in Melbourne hospitals that I've worked at, the triage nurse is often quite important, taking OBS and also embedding sepsis recognition as part of that. It's definitely not done consistently. So we've shared one paper in the chat which highlights the role of early nursing recognition and allocating the correct triage category, which has shown a significant improvement in the time to sepsis recognition and management. And so a lot of these things are programmatic and systematic interventions that we can do, but that just highlights another huge role for nursing recognition. And even if it's not, I guess, part of your hospital pathway, helping the nurses to put their patients onto that pathway at any point, whether it's at triage or handover or any point in their care, is quite important.
Absolutely, and 80% of our sepsis cases come through ED. So, and the triage nurse is an extremely important cog in this wheel in early recognition.
Do you think there is any capacity to make nursing role of taking observations at triage more widespread in Queensland? Is there a reason why that's not more widespread?
They stopped it due to COVID, and the fact that they were, you know, having taken so long to just triage one case. So they stopped it. So technically they should be done obs pretty quickly afterwards. It can be variable depending on, we're all having issues, aren't we, with seasonal flu and COVID still, with staffing shortages. So I don't think I'll have any success in getting that changed. They're quite happy the way it is. So
I'd love to hear if there's anyone in the audience who does have any different experiences that would like to share. That would be excellent. In the meantime, our director, Kaz Thursky, has been instrumental in drafting a curriculum for advanced nursing practice in AMS and sepsis. So if anyone does want to know more about that, feel free to reach out to us. We've shared our contact details in the chat. We have Belinda was online, but Belinda's one of our first nurse practitioners who has gone through that process, which is quite exciting, and would love to expand that more widely. We've also recently published our circular, our regular NAP circular on the topic of sepsis, and so we were able to describe the antimicrobial prescribing and appropriateness in sepsis in Australian hospitals, which is quite interesting. So if you haven't seen that, you can follow that on the NCAS page. And
we just email you for that AMS Advanced Nursing Practice. Okay.
Yes,
I'll just send that around to my team.
Yes, please. Yes. Feel free to email me directly, Celine, or we've got the general NCAS email in the chat as well. We've also got the link to the circular. So I think we're a few minutes over, and obviously we'd love to keep chatting, but thank you, Celine, for joining us all the way from Queensland. Thank you, Sadid, for joining us early as well, in amongst everything else that you guys are doing.
My pleasure.
It's been very helpful. I'll let Josephine share our final announcements before we wrap up.
Thanks, everyone. And those were excellent talks from Sadid and Celine today. Just letting everybody know that next month's seminar topic will be around digital health, and that will take place on Wednesday, 16th of October. And very exciting to announce that in November, we'll be hosting a one-day in-person event here at the Peter Doherty Institute in Melbourne. And it'll be a workshop day around advancing antimicrobial stewardship and building workforce capacity for research. In the interest of time, I pasted the link that will take you to the events page, and that will have the program outlined here. Thanks, everybody, and see you next month.
Thanks, everyone. Take care.